Hypoglycemia, or low blood sugar, is the most common and one of the most feared complications of diabetes treatment. It must be taken seriously since patients can die from this condition. Having an episode of severe hypoglycemia raises the risk of mortality over the next 12 months by about 65%. Hypoglycemia is often triggered when patients with uncontrolled diabetes try to achieve tight control. You must think of hypoglycemia in a diabetes patient who presents with signs and symptoms of epinephrine release, like shakiness, anxiety, tremor, palpitations, and sweating. Usually patients with neuroglycopenia, or low brain blood sugar, have confusion, seizures, and coma. This is the difference between brain low blood sugar and body low blood sugar. Also, severe hypoglycemia, quote unquote, is defined as needing the help of another person to normalize the glucose. If a patient with diabetes presents with signs suggestive of hypoglycemia, remember the following. First, consider hypoglycemia even with normal sugar levels in a patient with previously uncontrolled diabetes. As their control improves, or if they have a rapidly falling blood sugar, they may feel symptoms of hypoglycemia. Second, you need to rule out mimicking conditions like acute myocardial ischemia or infection. Third, if patients need beta blockers for heart problems, counsel them that beta blockers do not usually completely eliminate the symptoms of hypoglycemia, but their symptoms might change. Most patients on beta blockers still have profuse sweats as a symptom of hypoglycemia, for example. Causes of hypoglycemia include 1. Too much insulin or sulfonylurea. 2. A mismatch of insulin, sulfonylurea, or exercise with food intake. 3. Continuing to take diabetes medicines when patients aren't eating and they have nausea, vomiting, or diarrhea. And 4. When patients develop decreased renal clearance of insulin or sulfonylureas. Most patients with mild or moderate hypoglycemia can self-treat with oral glucose like jelly beans, but hospitalization is often required for severe hypoglycemia since, by definition, the patient needs the help of another person to return their glucose to normal. Finally, remember to continue basal insulin in patients with type 1 diabetes, even if they have low blood sugar. They require insulin and will go into DKA if they don't have insulin at all times. Remember to give intravenous glucose as needed to increase the blood sugar while continuing basal insulin. Last, the key to lowering the risk of further episodes of hypoglycemia include a detailed understanding of the timing of the patient's medications, for example, their insulin, onset, peak, and duration, and matching that to what they eat and when they exercise. Frequent blood sugar monitoring is critical to avoiding hypoglycemia.